Welcome to this online forum, Quality Improvement for Cardiovascular Disease Prevention webinar, brought to you by SBK Healthcare.
So as Emma mentioned, I'm Hester Girling, and I'm a project manager for the CVDPREVENT audit, and I work for the NHS Benchmarking Network. So we run the sort of third work stream within the audit, and I'm joined by my colleague Liz. Liz, do you want to introduce yourself?
Thanks, Hester. Yes, I'm Liz Corteville. I'm a pharmacist based in southwest Hampshire. I work for Hampshire and Isle of Wight ICB, but I also work a couple of days a week as part of the NHS Benchmarking Network team on the CVDPREVENT audit as their quality improvement lead.
Amazing, thank you, Liz. So just to give you a bit of a rundown of how the session's going to go. So I'm going to give you a bit of an introduction into the audit and what it is. And then I'm going to do a bit of a demonstration of our online tool. So I'm going to show you how our online tool works and how you can access the data yourself. And then Liz is going to go into a bit on her work doing the quality improvement side of things. I can just hear someone, so I just, if anyone could just make sure they're muted, that would be fabulous. Thank you. So yeah, just to kick us off with an intro to what the audit is. The whole issue around cardiovascular disease and what's the urgency and why are we talking about this today. So on this slide, we've essentially taken a bit of information from a King's Fund report that was published in November 2022, which really highlighted what the issue around CVD prevention is and what we should be aiming to do within cardiovascular disease prevention. So I'm sure a lot of you know a lot of this already, but cardiovascular disease is a leading cause of morbidity, disability and health inequalities in England, and it causes 1 in 4 deaths in England. So we are aware that it is something that we really need to tackle to try and reduce this morbidity and try and improve people's quality of life. And as we all know, I'm sure, is that CVD is preventable. So by managing, properly diagnosing and treating some of the conditions that often lead to cardiovascular disease, you can prevent people from having heart attacks and strokes, which greatly affect their lives. Now, the King's Fund report started to look into what systems can be doing to tackle cardiovascular disease in their local area. And in particular, we've circled down on this slide that reducing clinical variation is really important. And that's sort of where the CVDPREVENT audit comes in, because with the CVDPREVENT audit data, what you can do is you can start to recognize where that clinical variation is, so that then you can start trying to tackle it and trying to reduce it. So in terms of the audit itself and how we structure it, we created this driver diagram to try and take you through from our overall ambition through to some of the indicators we look at, and then how that translates into some of the quality improvement work that happens on the ground. So to take you through this from left to right, so we start with this ambition, which is to support the long-term plan aim, which is to prevent 150,000 strokes, heart attacks and cases of dementia by 2029. So we're just one small sort of cog in the machine working towards achieving that ambition. We then thought to ourselves, well, to sort of check if we are achieving this goal, what kind of key questions do we need to answer with the data? So we split it into 4 key questions that cover the kind of patient pathway through kind of prevention of cardiovascular disease. So first off, we want to look at whether or not people with high risk conditions are being identified as having them. Then we want to look at whether or not people with high risk conditions are being properly diagnosed and coded with those diagnoses. Then we want to know whether or not, once they've had that diagnosis, if they're being treated and managed to guidance. And then finally, we want to check that if there's a potential that people might be being over-treated. So those are the 4 key questions that we want to answer. And then the green box on this slide kind of represents the types of indicators that we have to capture some of this information. So I haven't been able to list all the indicators on there because we've got too many, but just to give you an example, for that first question on whether or not people are being identified, we look at the sort of things such as how many people have readings that suggest they have a high risk condition but don't have a diagnosis of it recorded. So that's sort of highlighting the unidentified cohort of people, for example. Once we have all those indicators and we have all the data for that indicators, we then move on to that final blue box, which is about translating that into quality improvement work on the ground. So we need to think about sort of the resources and equipment we can give to people working in practices in primary care to sort of start tackling these issues. So that's our driver diagram. Just to explain what the data is and where it comes from and who it comes from. So it is an audit that looks only at primary care, and we get all of our data from GP systems. So the data is extracted automatically from GP systems via what they call a GPES extract. So the really good thing about that means that once a GP chooses to participate, there's no data burden on them. Their raw data is lifted automatically from systems, which is great. And then we don't collect data from every single person on a GP register. We only look at the data from specific groups of people, and there are 3 cohorts to this. So first off, we look at anyone with with a diagnosis of one of the 6 high-risk conditions. So that is anyone with a code diagnosis of hypertension, atrial fibrillation, high cholesterol, which includes familial hypercholesterolemia. We've also got chronic kidney disease, pre-diabetes, and type 1 or type 2 diabetes. So those are all the people with the high-risk conditions that we can manage and treat better in primary care to sort of prevent people from getting cardiovascular disease in the first instance. We then have cohort 2, and that's anyone with a pre-existing diagnosis of cardiovascular disease itself. So that's anyone that's had stroke, heart failure, coronary heart disease, etc. So for this group of people, we want to prevent them from having sort of repeat strokes and heart attacks and make sure we're caring for them appropriately. And then our third cohort is really to get into that identification point. So it's what we call the case finder cohort. So anyone which has a clinical record with readings that suggest that they might have an undiagnosed high-risk condition. So for example, they might have a really high blood pressure reading on their record, but they don't have a hypertension diagnosis. Then on top of that, we also have health inequalities markers. So I did mention health inequalities on my first slide. So we know that health inequalities is a really big factor in this, and we wanted to collect data that sort of started to highlight where there might be differences between different demographic groups. So for every single person, where we can, we collect age, sex, ethnicity, and deprivation information, so then we can report our indicators with these breakdowns, so we can start to see where the differences are between these groups. So just to quickly explain our indicators and what they cover. So as I mentioned, this is actually a screenshot from our online tool, which I will go through with you in a minute. But as I mentioned, we mainly look at the 6 high-risk conditions that lead to cardiovascular disease, but then we also have a couple of indicators around smoking, and then we also have an indicator on cardiovascular disease itself, so the prevalence of cardiovascular disease. And then just to break that down, so looking into a bit more detail, for example, for the hypertension condition. So for each of those conditions, what we try and do is we try and cover the whole pathway for the patient through having that condition. So through from identification through to treatment. So for example, you can see here we go from a case finder indicator, which looks at, case finding people we don't know have hypertension already. We then look at prevalence, so look at the diagnosis and the prevalence of hypertension. And we go through to management and treatment indicators, and then we also look at potential overtreatment. So within each of these conditions, we try and cover that whole sort of journey for the patient. And then in terms of outputs, so we have 2 key forms of outputs essentially. So the first one is our annual audit reports. And now these are our kind of national summary of the data. So they look at the data from a national perspective, and then they outline the sort of key findings and key recommendations that we can take from the data as a country. So we've published a first annual report and a second annual report. So they're really good to start getting an overview and start to think where the key improvement opportunities are. And then we are currently developing the third annual report. So the third annual report is being published actually very soon. So it is provisionally scheduled to be published on the 9th of March. So literally in about a week's time. And then we will then start looking at writing up the 4th annual report too. Just to note, you might be a bit confused by those dates because they are definitely more frequent than annual at the moment. That is simply because we had a bit of a delay at the beginning due to COVID. So at the very start, we were doing a bit of catch up with our annual reports, but eventually we should be getting to a point where they are regularly every year. And then the final output, which is the output that I'm going to demo to you today, is our data and improvement tool. Now, this is our really key resource for people in the system wanting to access the data yourself for your own organization. So this is where you can find all of the organizational level data. So if you want to look at specific ICB, so a specific system, or if you want to look at specific practice or a specific PCM, this tool is completely publicly available and has all of that data on there for you. So as I mentioned, it's aggregated, so you can look at a region, an ICB, a sub-ICB, a PCN, or a practice. We then have benchmarks on there, so you can sort of see where you are against the national values, as well as sort of median values to see how well you're doing compared to other people. And then also you have sort of local comparisons, so there's sort of local peer groups that you can compare yourself against as well. We then also have health inequalities charts. We have spark lines to show trends over time. And we also update this much more regularly. So we update this quarterly now. So it's got new data on it every 3 months. And it will only ever be sort of 4 months old. So at this point of publication, the data will be sort of 4 months old at that point. So it's the most sort of frequent and timely data that we currently have on cardiovascular disease prevention. So this is what I'm going to demo to you now and just take you through a bit of an example on how it works. So I'll just get it up here. So when you go to that URL, you'll be taken to the home page, which looks like this. So this is our home page, and we have the demonstration video there. So you can click on that button if you want to go to the demonstration video. And then we've got the 3 main sections, so quality improvement tool, data explorer, and data extracts page. So if I start with the quality improvement tool, if you click on here, the first thing you're going to have to do is select your sort of preferences on the blue bar. So this is basically to select the time period you want to look at and also the specific organization you want to look at. So I'm going to look at the September 2022 data because that's the most up-to-date data we have. And then I'm just going to look at a local PCN to me. So this is a PCN example. So if I click on that there, what the quality improvement tool will do is it pulls off and tries to give a bit of a summary of all of the indicators that we have for your chosen organization. So it is categorized by condition. But if you'll see if I select hypertension there, it pulls off all of the hypertension indicators that you can view for your specific PCM. So to go through what each of these boxes means, so we've got one sort of rectangle per indicator. And this one looks at the percentage of patients with hypertension that have had a blood pressure reading in the last 12 months. And the first thing it will give you is an area value. So that is the value for this specific area. So we know that for this PCN, they have 78.5% of people with a blood pressure reading in the last 12 months. That's then compared to a system median. So that takes the median value for the system level you've chosen. So that's, for this example, the median when you look at all PCNs in England. We then have a quintiles bar, and this will highlight in purple where your selected organisation sits compared to other PCNs. So you can see here that this PCN sits in the middle quintile, so it's fairly near the median value. As you can see here, it's just a bit below the system median, but it sits in that middle quintile. And then you also have trend lines here, so you can see over time how this is trended for this indicator. So if I look at a sort of overview for hypertension for this PCN, you can see here they're sort of sitting in the middle for most of these indicators. But if you look here at this sort of trend line, we can see there is a bit of a dip here, which is suggesting that there was a bit of a drop in hypertension monitoring during the pandemic year, which is something we saw across the board and was a sort of understandable impact of lockdown. So then you might want to think sort of what impact does this monitoring have? You know, how does this affect, you know, how I'm working towards national ambitions, national targets? So we know that hypertension monitoring affects treatment to target figures, and we know that there's a new operational planning guidance target that is asking that 77% of people with hypertension are treated to target. So you might want to think that we might look into this indicator here. So this is GP recorded hypertension that have had a blood pressure reading below their age appropriate treatment threshold. So if I wanted to take a deeper look into this, I could click on the Explore Data button here, and that takes you straight to the Data Explorer page. And the difference here is, so where the quality improvement kind of pulls together lots of indicators at once, this just takes one indicator and goes into detail for that indicator. So we've got our treatment to target indicator here. And then we've got the area value, system median, and national value as we had for had on the quality improvement tool. So that's all the same. But then we also have inequalities markers here. So this is where you can kind of really start getting down into detail of some of the demographic factors and some of the inequalities markers that you know, we can see there might be differences between. So for example, if we look at this ethnicity chart, we can see that this for this PCN, we can see that the Black and mixed ethnic groups seem to be having sort of lower values when compared to the Asian and white groups. So that might be a specific group that we want to look at. I can actually just see in the chat, so the inequalities markers do normally include deprivation. It's just that for specific indicators and specific levels, we won't have certain breakdowns. So I think if you go to a higher up level, like to an ITB level, you'll be able to see deprivation, but at the PCN level, we unfortunately aren't able to have deprivation. So it kind of depends specifically what you're looking at, what you can get out of it. So yeah. And then finally, if we look at this related areas section, so what this chart on the left will do, it will take your specific organization that you've chosen. For this example, it's the PCN that I've chosen. It will highlight where you are at in sort of pink. So you can see here if this PCN is kind of upper middle compared to all other PCNs that sit within the same sub-ICB. And then we also have the lower system level areas. So what that will do, it will take your chosen organization, so this chosen PCN, and then it will break down all of the sort of practices below that. So depending on what level you are, it will go one level down and show you where those organizations are sitting. So you can see there is variation between practices here in terms of how well they're doing for their treatment to target indicators. And then last but not least, I'll just mention the final tab, so the final section. We do have a data extracts function. So if you want to take some of this data and download it and do some sort of your own analysis and to like work it into your own charts, you can specify a time period, a system level, so for example ICB, and then select an indicator, and that will pull the data off for you, which you can download into a CSV file. So that is me. So I'm going to hand over to Liz now to go through some of her QI work, and hopefully my screen will continue sharing. Do you want to just let me know if it doesn't?
Yeah, so
yeah, it looks great.
Demonstration.
Fab, cool. I will pass over to you then, Liz. Thank you.
Okay, thanks very much, Hester. That was a really good introduction into what the data looks like. And I suppose my brief is to share with you how you might then apply that data and how you can use it to help improve things at local level. So I guess the starting point is, what are we trying to achieve, and what are we trying to do together? I've put up the sort of NHS change model as a sort of guiding a guiding approach to how we might want to improve things. But right at the centre is our shared purpose. So if we can move on to the next slide, please, Hester. It may be that you're from a PCN or a practice and you're wanting to look at it from a point of view of an alignment with primary care contracts. Some of the things that we're talking about improving with respect to cardiovascular disease are incentivised in the primary care contracts, either in QOF or the PCN DES. Next slide, please. It may be that you're looking at it from a point of view of recovering from the pandemic, and we know that there was some RCGP guidance on how to improve some of the cardiovascular and other long-term conditions that were published last summer. And if we move on to the next slide, please. It may be that you're approaching it from the point of view of reducing healthcare inequalities and the core 20+5. So, and of course, some of us are looking at it from all those different aspects. So it's about trying to pull together that shared purpose and quite clearly work out what it is specifically that you're trying to improve when you're looking at such a rich data source as the CVDPREVENT audit data. Next slide, please. So what we've been doing locally in Hampshire and Isle of Wight has been to offer educational outreach meetings. Now, traditionally, they're sometimes called academic detailing or sort of similar names, but the purpose of these meetings is to gather together at local level a bunch of people who have a shared purpose to improve something about cardiovascular disease prevention in this particular example. So what we've been doing is we've been using the CVDPREVENT audit data as our primary source of data, mainly because we can benchmark that to all other practices and PCNs and regions in the whole country. And where that's been possible, we've supplemented it with more local data, but just to try to get a very data-driven approach to making change happen and have that gathering of individuals, of relevant individuals, as multidisciplinary as possible to try and see what it is and from what perspective we need to try and change things. Then we've been engaging people in a conversation about cardiovascular disease prevention and sharing some of the resources that we can go through today in the webinar that have been really helpful to prioritise and risk stratify some of these interventions. And then thirdly, it's about trying to pin down some sort of action plan. It can be really quite overwhelming with some of these CVD topics to know where to start, and the huge numbers of patients that are often involved that need some attention, particularly post-pandemic. So it's really important to try and have an action plan where you divvy up the work and you decide who's going to do what. This is not something that can fall on the shoulders of one or two individuals in a practice or in a PCN. It does require that whole teamwork, and both clinical and non-clinical staff need to engage if we want to make that change happen. So next slide, please. This is really just to say that in their King's Fund report, they did highlight this as a case study of how ICBs could perhaps facilitate some of that change to happen, is to offer educational outreach visits. And I think if we go on to the next slide, I've just put on there the sorts of things that you might discuss at such a meeting. Obviously, we just talked about some of those things, and one of the things that we're doing within the CVDPREVENT team is to offer some training on delivering educational outreach meetings on CVD prevention, utilising the CVDPREVENT audit data as that source for being the catalyst for change. Next slide, please. So just really wanted to offer that up if you're from an ICB, or if you're from an organisation where you're in a position to gather together some local facilitators. It works best with local facilitators. We're offering some training on delivering these educational outreach meetings, and sort of the facilitators might be medicines optimization teams in ICBs. They might be other sort of transformation teams, population health management teams. All these people are potentially suitable for delivering these these educational outreach meetings. And what we've found is we've done this not just with CVD prevention. It's a highly successful technique for bringing about change in complex environments such as prescribing. So we've done it for antimicrobial stewardship and other types of therapeutic area, but it works really, really well. And we're suggesting to anybody who would like to take up our offer to get in touch with us. I think the next slide has the details of who to contact. Oh no, it's on the previous slide. So I guess the starting point is, what are you trying to improve? And I'm just using this as an example from a medicines optimization point of view, which is how we've approached it in Hampshire and Isle of Wight. Obviously, for us, having had a look at our data, our CVD Prevent data, it was very, very clear that our hypertension management and our cholesterol management were very much in need of optimizing. I think for both hypertension and cholesterol, we're very much at the bottom end of the scale performance-wise as an ICB. And in fact, as part of the Southeast region, we're very much at the bottom end of that spectrum as well. So we had a very compelling need to look at both aspects of cardiovascular disease prevention. Next slide, please. What we did is we took the data, we did a download. We've got a really clever analyst who downloaded some of our CVD Prevent audit data. You can't really see the detail on that slide, but it was really just to say we were able to visually quite quickly see where different places within our organization, different PCNs, were with respect to the national average, with respect to targets that might have been set. And we're able to see what sort of things needed our urgent attention and in what priority we're going to do that work. So next slide, please. For example, it was quite clear that we needed to do some work on optimizing blood pressure management, and we were able to, from the CVD Prevent audit data, work out that we had about 50,000 people across Hampshire and Isle of Wight who had hypertension but weren't being optimally managed, or at least whose blood pressure was not optimally managed, because that it's not necessarily a sort of a failure on the side of the practices or the sort of clinicians. We know that sometimes patients don't necessarily engage and don't necessarily comply with their medications, but that gives you an idea of the sort of scale of the problem. And the other thing that we were able to see quite quickly and easily is that we had 60,000 patients who were known to be hypertensives but hadn't had a blood pressure reading in the last 12 months. So that was a very specific thing. And obviously you can't have your blood pressure treatment to target if you haven't got a recent record of what your blood pressure is. So the two go hand in hand, but it struck us that there was some quick wins in terms of sort of looking at the patients who hadn't had a blood pressure recording done. So the slides have come back again, haven't they? So can we move on to the next slide, please? So part of what we've been doing at these educational outreach meetings is to talk about the sort of the resources that are available, and if you can actually specifically target certain things that need improving, you can prioritize some of those patients. You know, if you're talking about for example, in a practice where they had quite low blood pressure managed to target readings, we found that there were 700 patients who hadn't had a recent blood pressure done. So we were able to work together with them to specifically focus on getting some blood pressure readings in for those patients. And I'll come on to that in a bit more detail later on. But that's the sort of thing, using UCL partners, the proactive care searches, and lots and lots of resources that they've got available. They're free resources, they're available to all. It's really possible to do some very good quality improvement work. And of course, by having these meetings, you can share top tips from colleagues and other practices, and you can use a lot of the materials that some of the third sector, the voluntary sector, have made available for patients. Next slide, please. So here are some examples of things that people have done and ideas that people have come up with. So we've mentioned already using some of those UCL partners searches to identify patients. Now, I'll go through them in a bit more detail, using some of the digital solutions that are available to us. So, for example, using our AccuRx and Flores and other sort of communication packages that are part of clinical systems or that sit alongside them. We've been very much using the pharmacy workforce to drive forward the agenda, because we've trained up our medicines optimisation teams, and we've been working very closely with the PCN pharmacy technician and pharmacist teams. And there are definitely some quick wins that you can make by engaging with that workforce. And the other side of things is to link in with the comprehensive medication review, the structured medication review work that is being very much promoted as part of the PCN DES, where you can combine several indicators to really maximise your alignment with some of these primary care contracts. Next slide, please. So this is an example of the UCL partners search for hypertension. I'm not going to go into it in great detail, just to say that there are different priorities. The priority one, the urgent patients, are those patients who are really far from target, and people have been tending to sort of work out locally how they're going to deal with those patients. Typically in a practice, there aren't thankfully too many of those patients, so you can usually work and work on that list of patients and engage them with the work. Then there are the sort of priority 2 and 3 patients that kind of fall in the middle. The priority 4 are the people whose blood pressure is well controlled, and really you just need to have a system in place to help the recall system tick over nicely and call these people in, but they don't necessarily need any clinical involvement at that moment in time. So it's about trying to risk stratify and prioritize some of these patients. And you can see that in the priority 2C, the patients who haven't had a recent blood pressure reading. So next slide, please. Really, this is a similar sort of thing with cholesterol as the basis, and this is looking specifically at secondary prevention and lipid management in patients with known atherosclerotic CVD, but there are flow charts for primary prevention as well, and it's possible to sort of put patients into order of priority. If we go on to the next slide. So just looking at one of the quick wins that I mentioned earlier, if you look at the 60,000 known hypertensives in Hampshire and Isle of Wight who haven't had a blood pressure reading recorded in their notes recently, we can put a very simple process in place to try and make sure that we can call these people in and we can reach some of these people who may not have come forward. So I think I've shared the process on the next slide. Not quite. This is just showing how one of our highest performing practices is a practice on the Isle of Wight, and they're currently their blood pressure treatment to target is just over 80%. This is on the September 22 data. I have to say that the range varies from about 35% of a practice's total hypertensive population treated to target to 80% in this case. So if we move on to the next slide, you can see that part of the reason that this practice is so good at monitoring their hypertensives is that they've got really great processes in place for monitoring hypertension. So monitoring hypertension and managing hypertension go hand in hand. They're around the 95% mark for monitoring of blood pressure. Next slide, please. So this was a little process that some of our technicians, our senior pharmacy technicians, put together with the technicians, and it's just about trying to identify these patients who are in the UCL Partners 2C category, i.e. they haven't had a recent blood pressure check, doesn't require a lot of clinician input. This is something that's been managed by the technicians, and they've been linking in with some of the admin people in the practice. So just trying to find patients who haven't had a recent blood pressure check, send them a message, ask them if they've got their own home blood pressure monitor, and if they have, please could they send in some blood pressure readings, and so on. If not, perhaps they can link them with a local pharmacy, or with ask them to come into the surgery to some of the blood pressure pods. It's really not rocket science, this, and many practices that we spoke to said, oh yes, we've done all that and we still can't get people to come in. But actually, when you start to unpick it and you start to have the conversations, you find that the local pharmacies are really crying out for some of these patients to come, and they've got quite good capacity, and yet nobody seems to be sending them any patients, or they've sent messages out and sort of en masse and nobody's sort of followed up, or they might have sent a message asking for a whole week's worth of blood pressure readings. For some of these patients, it's acceptable to have a single blood pressure reading, and then if that's high, you might want to follow it up. But I think sometimes if you don't unpick some of the complications and some of the barriers to people getting back to you, you don't actually manage to see change happening in that front. So it's only since we started using our technicians in that way to try and unpick some of that we found that there's been huge differences in what practices have been able to achieve, and we've seen that patients are coming in and engaging with that process now. Next slide, please. So I've put that in there. You can't really read it on the slide for now, but it's just if you're interested in seeing what the process is that the technicians have put together, can be adapted. It doesn't have to be done by technicians. It can be adapted by anybody in the practice, and how they've sort of split that up into the UCL Partners priority sections. So that's just there if you want to refer back to it after the webinar. Next slide, please. And then I've also put in some examples of how the pharmacy workforce have been conducting some structured medication reviews and optimizing, not just blood pressure optimization, but obviously if you look at a patient's risks of cardiovascular disease, in a holistic way, many of them will need to have their lipids optimized and any other risk factors that they might have. So these are just some cases where the pharmacy, this is in one particular PCN with just some examples of what's happened to these 5 patients. And you can see that in one particular patient, they managed to pick up that the patient actually had familial hypercholesterolemia by conducting a blood pressure review. So it's possible to have a very holistic, making every contact count approach to this, and to be able to combine different risk factors. Next slide, please. This is an example of some work that the pharmacy workforce have been doing with some of the UCL partners, just to show some of the kind of breakdown of numbers. So different practices where they've run the UCL partners searches, and you can see that, you know, in that last practice, practice number 4, 315 patients in that practice have got known cardiovascular disease and are not on a statin. I mean, some of them may have declined a statin, and there are lots and lots of barriers to statin use. So not pointing a finger of blame, I'm just saying 315 people who possibly could be on a statin and lipid lowering therapy are not currently, and that definitely needs some attention if we're going to try and prevent the huge burden of CVD that we know that we're carrying in this country. So next slide, please. These are a few examples of cases where the pharmacy workforce have looked at it. The first priority 1 patient on there really is really satisfying to see. It was a 58-year-old male. He'd had a heart attack back in 2012, and he just stopped taking his statin. And it wasn't until he got a phone call from the pharmacist doing a review of his medications, and he said, yeah, I'm happy to restart. I don't really know why I'd stopped. And it was also noticed that he was due to be on an antiplatelet agent, and that was started as well. So there are some quick wins. The trouble is you do have to make contact with patients, and I'm not saying everybody's going to be as easy as that, but that was one really good example of where it was well worth that phone call just to check what was happening with that patient. So next slide, please. This was some work that one of my colleagues in one of the PCNs presented at a recent webinar that we had about primary prevention. This is a group of practices in Portsdown and Portsmouth who have been working very much. They've been getting technicians involved in looking at patients who have a risk score, Q risk score of 10% or more, and they've been really focusing on contacting those patients and offering them lipid lowering therapy. And as a result, they're one of the top PCNs in their area. They've managed to get 52% of their patients onto lipid lowering therapy. So again, that's really just because you're able to highlight what areas might require improvement and how you differ from your peers, either from a sort of ICB perspective, looking at different PCNs and where the pockets might be, or from a PCN perspective, focusing on which practices might need a bit of extra help. Next slide, please. It would be remiss of me not to mention the equity focused approach. There's an argument that if you only look at the sort of risk stratification and prioritization in something like UCLP searches, you might be making some of the gap between the sort of certain parts of the population worse. And so instead of reducing healthcare inequalities, you can maybe worsen those inequalities. So if you're using an equity focused approach, it's very much about seeking out and engaging with certain communities where you know that perhaps management isn't optimal, and specifically trying to drive standards up in those particular cohorts. And that may be for a whole variety of reasons. Again, I'm not sort of pointing the finger of blame. There may be all sorts of reasons why certain cohorts or communities aren't engaging, but it's really important to specifically target those communities if you're wanting to not just raise the median, but to actually raise the median for that particular group of people. So next slide, please. Just really wanted to emphasize the importance of trying to have an actual plan and to divvy up some of the workload that's required, because unless you specifically single out some of these actions that need to be taken, it's quite difficult to make that progress and to follow up on them. So we're very much it is up to an individual practice, an individual PCN, individual place to work out what their priorities for improvement are, and our role is to use some of the data that we've got to help assist with that and to facilitate some of these actions, and try to connect people and put people in touch with each other so that they can form networks or share good ideas and best practice. So next slide, please. So that was my final slide, and I think I'm going to go over to some questions.
Yeah, so we do have some questions in the Q&A box, so I'll just start firing them towards you, Liz, if that's okay. So the first one was, how do we access the CVD Prevent Train the Trainer course for educational outreach?
So I think anybody that's interested in getting a few people together to train as facilitators, if you just get in touch with us, I'll put the NHS Benchmarking contact in the chat bar, and yeah, we can take it from there. It's really worth thinking about it if you're a medicines optimization team, or if you're involved with an ICB. It's worth thinking at this time of year in particular about including something like that as part of engagement of a prescribing incentive scheme or a medicines optimization incentive scheme. So the requirement to have a meeting, it's really worth thinking about putting a small incentive in that. Obviously, a lot of these indicators are incentivized in other ways. They're aligned with various other GP contracts, but the actual having a meeting and having some of these discussions is well worth incentivizing if at all possible.
Fab. Thanks. Okay, so the next one is, how do I access the UCL partner risk stratification searches, and what is the cost to my practice?
So I think I mentioned in the talk that they're free of charge. You can just Google UCL partners proactive care frameworks. I can put a link in the chat bar. But yeah, you can just, there's loads and loads of resources there that you can access. And you just have to register to be able to download the searches and to run them on your clinical system. They've got searches for System 1 and they've got searches for EMIS Web.
Perfect. So this one's maybe a bit more specifically about some of your work in Hampshire and Isle of Wight. So how much involvement was there from secondary care, i.e. where patients were found to need escalation of treatment?
So we work very closely with secondary care, and as part of the sort of Wessex integrated cardiac delivery network, we've been very much linked up with secondary care. To be honest, a lot of the patients that we're talking about are patients who need to be optimized. It's very, very basic. Undoubtedly, there's a need for for more complex patients to be seen in secondary care. But a lot of the groundwork is about looking at some very simple things. Lipid management has not been part of QOF for the last sort of 12, 13 years. And I think since it was taken out of QOF, standards have dropped. From the point of view of blood pressure treatment to target, it is part of QOF. But as we know from the things that Hester was saying, we know that during the pandemic, things took a real knock and patients weren't necessarily having their blood pressure recorded during lockdown, etc. So we do need to be able to sort of highlight those patients and do some work on those, and the bulk of it is in primary care. So it's really important to kind of realize that and and to be able to put in place systems that allow people to get through some of these large numbers of patients that we're talking about.
Fab. Thanks, Liz. And then we just have one last one. So it asks, how can we audit patients with multiple CVD risk factors? Which is an interesting one.
So that is one of the challenges, and certainly at the moment, some of the CVD prevent indicators will allow you to benchmark according to each indicator in isolation. But of course, we know that many of these patients have got multiple morbidities, and there's a very exciting development in the form of a new tool, CVD Action, that is being worked on by the UCL partners. And from what I can understand, that will allow us to risk stratify patients who have multiple morbidities, and you can then sort of pull them together. At the moment, the only way to do that is to run the searches and then further try and combine patients who are identified through individual searches.
Yeah, perfect. We did do a bit of a deep dive actually as well. It's worth noting in the first annual report into some of the comorbidity stuff, but we've not picked up on that again since then. So that might be something we want to focus on again in the future.
To find out more about further educational podcasts, webinars and forums, please do visit our website at www.spk-healthcare.co.uk. Thank you.